Deb, I'm gonna unmute you. And your question was with regards, if you want to, actually, I think you're still muted. You're like doubling. There you go. The practical advice and the safety recommendations, I think.
Goodness, I don't even remember
you want
what I asked.
Well, I'll read it. Okay. So
Yeah, that'd be great.
what kinds of aids, practical advice can we safely recommend to our clients? I've had clients doing all sorts of unsafe things in order to keep their babies more comfortable, sleeping in strollers, using wedges, co-sleeping. I'd also like to know how many babies actually have reflux, as many pediatricians I've spoken to have told me that babies spit up, throw up a great deal of fluid, and that's fairly normal and can be outgrown, and therefore should not interfere with or delay sleep training. Is that what you believe in as well?
Well, I think, that's a very good question. I think a very important thing to consider is that not all babies who are fussy have reflux. It's very easy to attribute the fussiness to reflux, but I can tell you, I see a lot of fussy babies, and we manage them. We manage their reflux perfectly well, and they remain fussy. So there are many other reasons for babies to be fussy. So I think that's a very important point to mention. Another important point to mention, as you pointed out, is that reflux is normal. It's normal to have reflux. If babies don't have reflux, they can be even more uncomfortable, and that's sort of evidenced by the fact that when we do these Nissen fundoplications, these infants can be extremely uncomfortable. So reflux is a normal physiologic phenomenon that babies need to have. So I think reflux is probably overdiagnosed, and as a result of that, it's probably overtreated as well. And the problem is, it's difficult to make the diagnosis. In order to really make a diagnosis of gastroesophageal reflux disease, and I'm using the word disease here, theoretically the child should undergo an endoscopy and a biopsy, and showing that there's actual inflammation in the esophagus. And to take a young infant and give that child a general anesthetic and do an endoscopy on that child is a big deal. So we often don't do that. So I think reflux is often overdiagnosed.
Mm-hmm. Thank you.
All right. Now let me mute you again. Okay, and actually I have a question. Renee is not here, as I mentioned. She's from St. Louis, as you know. She asked the question, do you have any thoughts on chiropractic treatment assisting infant reflux?
Right. I haven't had direct experience with that, but I think depending on what the anatomy is of the child's skeletal system, I would think that there may be an association, and I'll just mention sort of a phenomenon that we do see in infants, and that's something called Sandifer syndrome, where when a child, sometimes we'll get children that when they are uncomfortable and they're having an episode of reflux, they'll kind of turn their heads and they'll kind of stretch out, or they'll arch, and they'll sort of do some contortions of their spines and their heads and their necks, and that often sort of has been the reason they're doing that is that they're clearing the esophagus. They essentially have learnt how to clear the esophagus of that acid that's causing them such discomfort. So there's no question, that there's an association between making reflux better and sort of doing some contortion. So I would think that the corollary to that would be, maybe doing some manipulations potentially could help reflux, although I don't have any direct evidence for that.
Interesting. Okay, thank you. Okay, the next question I have, I think, let me see, is she here? Kelly, are you here? Okay, I guess she's not here. Okay, Kelly is from St. Louis as well. She says, I'm interested as to why the increase in cases of reflux in babies. Years ago when I worked in the NICU, it was a few babies here and there, and now both of my kids were diagnosed with it, and it seems like every third client is also.
Right. That's another great question. I think the answer to that is I'm not sure that there's an increased incidence of reflux. I think of true reflux. I think pediatricians are diagnosing it because of the fact that there are drugs available I think, and I don't want to sound sort of cynical or skeptical, but I think, corporate America has done a wonderful job of, marketing drugs for any for any condition that exists. And now, because of the fact that these drugs are available, the conditions that these drugs theoretically are being prescribed for are being diagnosed more frequently. So I am not sure that reflux in infants there's a greater incidence. I mean, potentially may be related to allergy, because we do see a higher incidence of allergy, but most reflux during infancy is not allergy related. I mean, most reflux in infancy is related to the fact that, for the reasons that I mentioned, these infants are drinking more liquids, that lower esophageal sphincter is just not as competent, infants are not sitting up. I mean, that hasn't changed for, hundreds of years, thousands of years. I think reflux in adults and in adolescents definitely has increased, and that you can attribute to lifestyle. I mean, that clearly is related to, obesity, lack of exercise, caffeinated beverages, sodas, essentially lifestyle changes. But in terms of true reflux in infancy, I really don't believe that the incidence has increased.
Okay. Yeah, we were talking about that, before. There's a question here from Laura, and I don't think I'm not sure if she has access to audio. So I'm just gonna answer or ask the question for her. She's out of Atlanta. She has actually a couple of questions,
Sure.
but they're good questions. So she says, I've had several clients, in my own experience with this as well, with reflux babies overeat solids and become uncomfortable, but still will not turn it down. Is this because it's soothing going down and they think it makes the reflux feel better? It's a very strange thing to watch it because they scream for more. This is a common thread I've been seeing with babies around 5 to 7 month mark. I guess it wouldn't be solids, right? Who are on the reflux meds as well.
Wait, I'm not sure I understand it. So what she's asking is, why do babies who overeat solids?
Yeah.
Because usually, and I didn't mention this in the slides, but usually infants that overdrink, so if a mother is literally giving a baby too much formula, that can definitely predispose to reflux. But usually overeating solids would not. I mean, unless in addition to the solids, the child is drinking as well.
Right.
But solids theoretically increased solids should not cause more reflux, unless there's some anatomical problem going on.
And this came up a lot about, how long is it really necessary to hold a baby upright after eating when they have reflux?
So what I usually recommend is, I mean, obviously, as soon as the baby burps, and if the baby has a great burp, I mean, theoretically you can stop. But I usually recommend, 5 to 7 minutes of upright positioning. Keeping the baby upright, and just trying to get that burp. And once that burp occurs, theoretically, you can put the baby down.
Yeah, because we really struggle with that, because it really interferes with our ability to, follow through with our routine, especially if they're tired, they're starting to get really tired, and then, of course, then they become overtired, and then there's crying. So, which then can, exacerbate the problem.
Right, it makes it. And another thing I just want to mention, Deborah, this is also a good point, is, you should also, depending on, obviously, there's always a big difference between breastfed and bottle-fed babies, but bottle-fed babies, you should always check the size of the hole in the nipple. If the hole is too small, that potentially could also cause a problem, because those babies could be sucking so hard that they're swallowing a lot of air. That's called aerophagia. And when those babies swallow a lot of air, that kind of distends the stomach, and that can also make them uncomfortable and fussy. So if the hole is too small in the nipple, that can cause problems. And obviously, if the hole is too big, then they're going to get too much volume, and that can also cause problems. So it's important to just make sure that the hole is not too small or not too big, if in a bottle-fed baby.
Yeah, really, there's a lot of detective work, eh?
Absolutely.
Sasha, let me unmute you. You have a question? Go ahead. Sasha?
Sure. Yes. Hi. Thank you.
You're welcome.
I was I was really interested in your comments about respiratory complications that can be related to reflux, and I just wanted to make sure I heard it right because we know how much OSA, obstructive sleep apnea, um, can interfere with sleep. So does reflux actually increase the risk of OSA itself, or does it just create other types of respiratory symptoms that could potentially disrupt sleep?
No, it can do both. So reflux can absolutely cause obstructive sleep apnea. I mean, when we've done, we do sleep studies on babies, we can do a pH probe, and we can correlate, reflux being associated with sleep apnea. So there's no question that reflux can absolutely cause obstructive sleep apnea. But in addition to that, there have also been a number of studies that have shown that just having the presence of refluxate in the distal esophagus, in other words, in the lower esophagus, can result in vagal mechanisms that can cause bronchospasm and can cause various airway responses in the absence of refluxate going all the way up into the oropharynx. So there's no question there's an association between reflux and apnea and reflux and respiratory symptoms via various sort of mechanisms, anatomical as well as sort of vagal reflexes. I don't know if that answers your question.
No, it does. I mean, that it makes a lot of sense, and it would just be another thing to talk to.
Right, and even if, and then there's something called
other symptoms of OSA as well as reflux.
Sorry, could you repeat that?
Yeah, I mean, if they're describing that they're actually noticing, OSA type of episodes where the child is choking or stops breathing, and then there also seem to be reflux symptoms. It's just another, a thing for them to be aware of.
Absolutely, and then there's another important point is, there's something called occult reflux where babies may not even have, overt sort of choking and vomiting and, gagging. They could just have, some discomfort, and that could be reflux, because the reflux could just be sort of occurring, in the distal esophagus, but that could be causing, inflammation. It could be causing some reflex vagal mechanisms. So even in the absence of overt sort of symptoms, reflux could still be present. But again, I don't want to sort of make you think that everything is reflux. I mean, I think overall, I think reflux is overdiagnosed. I really do.
Right. Okay. Thank you.
All right. Thank you. Let's give. Let's see. I think Amanda's had her hand up for a long time here. Okay, Amanda, you can unmute yourself. There you go.
Hi.
Hi.
Okay. I actually have two quick questions because I am dealing with a family right now that baby has reflux and she's on medication, and the mom says that she still just really can't get her to seem to want to eat enough to ever feel satisfied. Does that mean that the medication probably isn't working correctly, or?
Well, it could mean that the baby doesn't have reflux. I mean, it could be that the medication's not working, or the dosage may not be the right dosage. Some babies will be put onto a particular dosage, and as they grow, they outgrow the dose, so they may need a higher dose. So that certainly could be one possibility. Another possibility could be that the baby doesn't have reflux. As I said, reflux is often sort of, fussy babies often attributed as having reflux, but the baby could have colic. There could be other reasons for fussiness, and no matter how many drugs you give that baby for reflux, it's not going to resolve the fussiness. So it's hard to do, but I think the key thing in that particular family is the baby growing. If the baby's growing, that's very reassuring.
Yeah. Okay. And then you mentioned about burping, and do kids who have reflux have a harder time actually burping? And if so, is there anything that you can do to try and assist them?
Well, on the contrary, I mean, kids with reflux generally will burp more easily because essentially that lower esophageal sphincter is just not as efficient, and so they theoretically should be able to burp more easily. Sorry, and then your other question was, is there anything you can do to help them burp?
Yeah, other than just,
Right. Well,
patting
yeah,
them.
the usual. I think the key thing is keeping them upright, and really patting them is really not doing much. I think it's more the gravity phenomenon. I mean, keeping them upright is really the key thing. But patting them, I don't think does much. I think just if one keeps a baby upright, eventually that air in the stomach is going to is going to come through.
I always find moving them back and forth, from kind of like swaying them, like an accordion. I mean, not, drastically, but I always find
Right.
it works.
It's just sort of a gentle to and fro motion.
Exactly. Kind of pushes it up. Okay, and then, I want to throw on this question because I want to make sure, but it's from Mona. This is our sleep consultant in Romania. And she had a couple questions, but I really like this one. She asked about, okay, how many of the babies have frenum and reflux or lactose intolerance and reflux, where reflux is not the cause but the effect on something else?
Wait, what was the first one? Frenum?
That's the tongue tied.
Oh, frenulum, like a tie. Okay.
Also frenum. I don't know if it's
right. Okay. So, I mean, there's definitely some association between tongue tie and poor feeding, but generally, I don't think there's a very strong correlation between that and reflux. If the baby really has difficulty feeding and is swallowing a lot of air, I suppose that potentially could predispose that baby to more reflux. But to my knowledge, there's not a very strong association between a frenulum and reflux. Okay. And sorry, Deborah, what was the other part of her question?
The being lactose intolerance.
Oh, okay. Yeah, I can tell you lactose intolerance is almost non-existent in babies. That's another sort of diagnosis that I think is way overdiagnosed. I mean, true lactose intolerance in infants is a genetic disorder, and it's very, very rare. I mean, we'll see lactose intolerance in older kids, after they have, say, some viral gastroenteritis. But true lactose intolerance is extremely rare, and in my opinion, is really unrelated to reflux in infants.
That's really interesting.
And lactose intolerance, just bear in mind, lactose intolerance is not an allergy. Lactose intolerance, a lot of people think that lactose intolerance is milk allergy. It's actually not. It's basically not having an enzyme available in the GI tract that breaks down sugar, that digests sugar. That's essentially what lactose intolerance is. And as I said, it's very rare to have that in young infants. It'll occur temporarily in older kids after a viral infection. And the most common presenting sign and symptom of that is diarrhea and sort of abdominal discomfort, but not really reflux, and certainly not in infants.
Okay, very good. I'm going to unmute Arlene. Hey, Arlene. Hi. You got to speak up. There you go.
Yeah, I was just wondering if you'd ever seen massaging like the stomach and so forth, not right after eating, but if you've seen that as being effective to help improve just sort of the function of the digestive tract, and especially to improve the emptying of the stomach.
Right. I mean, I haven't personally seen that, but in theory, I mean, gently sort of massaging the stomach, I mean, with the hope of, causing that lower esophageal sphincter to relax may help reflux, but it's certainly not. I don't think there's much downside, obviously, provided one doesn't do it immediately after feeding and provided one doesn't sort of vigorously do it. I think, in terms of with the idea of sort of of causing that sphincter to relax may be helpful, but it's certainly nothing that's recommended by by pediatric gastroenterologists on a regular basis.
Okay, thank you.
Thank you. All right, and let's mute Luyin. She is from Halifax. Let's see, where are you? There you are. Okay.
Can you hear me?
Yep.
Yes.
Okay. Thank you very much for doing this talk, Dr. Sparrow. In fact, as other people are asking questions, it got me to ask even more questions. So sorry for that. I got about 5 of them. If you have the time for it.
I'm happy to do them.
Lovely. Okay, so my first question, just to spin off of that last thing you were talking about, the lactose intolerance.
Right.
Is it possible then to replace the gut flora to help them tolerate lactose better, or is that still in the research?
Well, again, I really think lactose intolerance is very, very rare. So, it's a genetic disorder where you don't have the gene that is responsible for producing that enzyme that breaks down lactose, and that's an extremely rare disorder. So, replacing gut flora with probiotics, in the hope of managing that, I really don't think there's a place for that. I mean, physiologically, that it just doesn't make sense.
Okay, thank you. All right, next question. This is the first time that I understand now why I'm understanding why some people are being told put cereal in your baby's formula. That's never been explained to me, and none of the clients I've worked for ever understood why their doctors were telling them to put cereal in formula.
Right, and that also supports the fact that, at 6 months of life, one of the reasons why reflux drops so significantly at 6 months is because that's when babies sit up, number one, but also that's when babies start having solids.
Right on. So how early do you recommend that parents start doing this if they feel they got a baby with reflux?
Right. So as I said, occasionally, usually prior to 4 months of life, we don't recommend solids. Usually between 4 and 6 months is when we introduce solids. But if a baby is really having significant reflux, is really uncomfortable, and is not losing any weight, I mean, we may introduce some rice cereal at around 3 months. I wouldn't do it prior to, say, 3 months of life. But at 3 months, you can kind of introduce, if in a particular way. I mean, ideally between 4 and 6 months is the time that we introduce solids.
Okay, so it's still sort of the same thing. You want to be sure your baby can still sit upright on their own, or at least hold their own head up high.
Well, it just in terms of solids, I mean, there's no relationship to that. I mean, there's no danger. I think the danger is not because the baby can't sit up at under 6 months of life. I think it's just much more harder to digest solids in the young GI tract as opposed to in the older GI tract.
Okay, and then if you start finding your baby ends up being constipated with this rice cereal,
yes,
what happens?
Right, and that's a good point. So, I mean, that's one of the downsides. So, if the baby has constipation, that's a whole other talk. I'm more than happy to give it another time. But constipation definitely can occur in babies that have too much rice cereal, and then in those babies we may recommend some prune juice, we may recommend suppositories, we may recommend Karo syrup. I mean, there are a whole host of things that we may recommend for those babies. I mean, provided that the solids are really helping their reflux.
Okay. So then my next question is, at what point do you start worrying then if you think you've got a baby with reflux and then it might end up being something more serious, say like pyloric stenosis?
Okay, so usually pyloric stenosis is gonna present itself within the first few weeks of life. Certainly within the first 3 or 4 weeks of life, those babies are going to manifest because they're going to have significant vomiting. They're going to have significant weight loss. I mean, that's one of the hallmarks as well. So again, if a baby is growing well, and I teach my students this all the time. I mean, if a child is growing well, if a baby is growing well, it's very unlikely that there's any major sort of process going on. But with pyloric stenosis, those babies are going to present fairly early on, and they're going to have failure to thrive. I mean, they're going to not gain any weight.
Okay, so we're not going to see that suddenly happen at 3 months.
No.
4 months.
No.
Okay.
Pretty quick.
Thank you.
Thank you, Joanne. I know we only have a few more minutes. He's got a client. He's got to see. But I see here, Erin, if you don't mind, I'm just going to ask your question here about when should we see results after being put on medication? When they.
Okay, that's a good question as well. So usually it takes a couple of days. I mean, if a baby has, now it depends on the medication again, but I would think that it's a proton pump inhibitor like Prilosec or Prevacid or one of those drugs. I mean, usually those babies respond within 24 to 48 hours, and the reason we're putting the babies onto those medicines is for pain. I mean, because those drugs are going to neutralize acid, and acid is what causes the inflammation in the esophagus, which causes the pain. So Usually within 24 to 48 hours, I mean, maybe 72 hours, I would expect those babies to start being much better.
Okay, that's good. That was a really common question. Especially for us to know, because unfortunately, that becomes kind of, obviously if the child is not sleeping well, they're crying a lot, so then the parents really can't decipher. They'll tend to kind of go with it's the reflux, but then we ask them if the child is being medicated.
Right.
You know what I mean? So like they tend to kind of really hang with the pain and the crying, but it's if they're crying all the time, it's quite different than
it's
crying.
Unlikely that it's if they're on medicines, it's unlikely it's the reflux.
Right, exactly. Okay, and then one last question, Lori. I'll get you unmuted here. You can be our last question. Go right ahead.
Thank you. I would like to know if what your thoughts are about when we do sleep training with babies. Obviously they're going to do some crying, and parents who have children with reflux are often very hesitant to allow their babies to cry at all. They're
Right.
going to exacerbate the reflux. But what I'm hearing from you is that if they're on medication, that should be an issue. What are your thoughts on crying, and if there is an issue, how long would you think crying would be okay?
Right. Again, that's also a very good question. And I think it also depends on the crying. I mean,
Sure.
if a baby is crying, and usually a mother can tell if the crying is truly crying out of pain, or is it crying out of hunger, or is it crying out of just wanting to be held? And again, that's a very subjective thing. But usually, you can tell if a baby's in pain. And if that's the case, I mean, that baby shouldn't be allowed to cry at all. I mean, if it's pain related, and that baby clearly should be placed on medication. Now, as far as being comforted is concerned and wanting to be with the parents are concerned, I mean, every pediatrician's got their own sort of approach to that. But as far as reflux is concerned, if it's pain related, I mean, the baby should not be in any pain at all from the reflux.
Gotcha.
Thank you.
All right, look, we gave you 2 minutes.
That's great.
To get ready for your client. But listen, thank you so much. This was terrific, and you answered all our questions. I went through all of them, and I think they're going to be thrilled when they see the recording. The ones who couldn't attend tonight. But again, thank you so much for taking the time to speak with us. Very insightful. Hopefully we can see you again.
My pleasure, Deborah. Any time. And if people have got other questions, I'd be more than happy. If they want to email me or email you, and you can email me, that's totally fine.
Oh, that's terrific. Really. Thank you so much. All right. Thank you. And all you have to do, because I know you have to go, you can just click off. And everybody else, thank you for coming tonight. Have a great week, and stay warm if you're on my end of the globe. All right. Okay. Thank you, Warren.
Thank you. Pleasure. Anytime.
Okay.
Okay. Bye-bye.
Bye, guys.